So I'd like to turn now to a discussion from our panelists. And the way this is going to work is I'm going to ask one overarching question that each panelist is going to respond to. And that question is, so from each of your research on the public's and policymakers' perspective, what are the major themes related to how the public or policymakers think the major challenges with health and healthcare are? And as you do that, it would be great if you could reflect on what you're seeing as either being complementary to or different from the major issues that our audience is bringing to this conversation. So to do this, I'd like to start with Venice, then move on to Eric, Julie, and finally David. So Venice, I'd love to hear from you.
Yes, thank you, Sarah, and thanks to all of you for joining us today. I'm super excited to be here and be part of this really important conversation. And just to kind of give a little context of where I'm coming from with my answers and perspective. I am, as Sarah mentioned, the Director of Research and Community Engagement at United States of Care. And United States of Care really operates as a nonpartisan, nonprofit organization to ensure that everybody has accessible, affordable healthcare regardless of social needs, status, or income. And so to do this work, we talk to people all around the country to really understand what the shared and diverse needs are from people on healthcare reform. And we usually use this doing a two-prong approach, really identifying opportunities in states as well as at the federal level. But we do all this work in partnership with policymakers, advocates, leaders, but most importantly, everyday people. And so we're really working to operationalize a people-centered policy design approach where we do that groundwork of listening to where the pain points are that people are experiencing every day and figuring out and taking those needs back to what we call our policy innovation hub and figuring out what policies exist that might be exacerbating those pain points and where the opportunities are to kind of shift what we understand, some opportunities to improve. So with that being said, what we're hearing on the ground so far overwhelmingly is cost. People are just overwhelmed with the sheer amount of issues that they're running up against, whether it be deductibles or high medical bills, and understanding how to elect into the choices that they have for insurance, making decisions between, eating and buying prescription drugs, or if they have a ostentatious medical bill for an unexpected procedure, and then the trickle down effects of what happens when they can't afford their health care on any one level. And so I'm reminded of a quote that actually bridges the other big issue people are experiencing, and that's accessible healthcare. And a lot of times when people are talking about this, it could be synonymous, like affordable care is synonymous with accessible care. And so we have a quote from somebody we talked to. They said, you might have access to really great care, but if you can't afford it, you really don't have access. It's a barrier. Care might come around the corner, but might be around the corner, but if you can't afford it, it's not accessible. So that's some findings from our qualitative work. And then from our public opinion polling that we just completed in November, same concept. They didn't identify any one particular area of cost, but it still, runs the gamut. So, thinking about this and then adding in the layers of those who have already have been exacerbated by an already, poorly structured healthcare system, particularly communities of color, older age groups, and those of lower socioeconomic backgrounds. This is exacerbated extensively. So definitely healthcare costs and accessibility across the board.
Great, thank you. I'll go next. Sarah, thank you again for hosting this panel today. And thank you to the National Academy staff and the Planning Committee for their work to put on a terrific panel. I'm with the Commonwealth Fund, a private philanthropy based in New York that actually is quite focused on research on health policy and on the possibilities. of reform in the healthcare system, whether it comes to insurance or healthcare delivery. We're in this question of what challenges are, how to frame the issue of reducing medical care spending to devote resources to more cost-effective health improvement strategies. We think there are two things that we need to sort of learn about the public's perceptions of these issues. And the reason the public's important is because the public votes, and politicians, to some extent, follow the lead of voters when they're not driving their voters in a particular direction. But the questions are, what are the public's views of the problem, and how do they conceptualize it? And what do they believe about the opportunity and solutions for improving things? So in those two areas, the issue of problems and the real questions are, what challenges are most salient to the public? How many people are affected by whatever those challenges are? Which segments of the public are affected? Not everyone is equally affected by policies. And how painful are these challenges? And how motivated are people to fix the challenges? And then second, we want to know about the range of possible solutions and what the constraints might be on any of those solutions related to the public's beliefs or values or views. Constraints tend to be defined in relation to values. And there are actually principles of behavioral economics also at play here that we could talk about later. But focusing on that first issue of how the public conceives of this, we've done surveys, and others have done similar surveys, and Venice just mentioned it. The cost of care is consistently among the biggest concerns related to healthcare. If you ask a general public adult audience that question, about half report that they have concerns about the cost of care or dissatisfied with the cost of care. So we often emphasize in our own work the numbers of uninsured, and the ACA did a lot to reduce the numbers of uninsured, but actually the cost of care rather than the number of uninsured is one of the most important concerns of the public. In the past decade, the survey work we've done has emphasized the cost burden that Venice also just referred to. Most people define the cost of care primarily in relation to their own out-of-pocket costs for premiums, copays, and deductibles. And we know from Commonwealth Fund surveys that the burdens, these cost burdens, have gone up dramatically as employers have shifted more of the cost of care onto the public over the past decade. So half of Americans report dissatisfaction with costs. And when we look at access, unfortunately, that doesn't poll as high. And quality is also not as high among the general public. Even among those who report costs as a concern, access, it polls less than 1 in 5 Americans identify that as among their concerns, and similarly with quality. So even among the half that report cost concerns, it's important to remember that people are very good at holding conflicting views, even within their own heads. All Americans believe that the US healthcare should treat everyone fairly, but many are also comfortable with the idea that wealthier people are entitled to more medical care than poorer people, as long as they're willing to pay for it. And I think that creates an interesting conundrum for us. So the issue on the table, as we see it, is what can be done to reduce my costs? That's what the public is thinking about. They're less worried about, as our audience is, whether aggregate spending on healthcare is too high. And it's also important to stress that a majority of Americans are satisfied with the status quo on access, quality, and costs, with costs maybe being a little more questionable. As a matter of politics, it's hard to force meaningful legislative change when so many Americans are still satisfied with the healthcare status quo, even if they're somewhat wrong about their perceptions of our system.
That's great. Julie, go ahead.
Yes, thank you, Sarah, for having me. And Eric, I think a lot of the research I'm going to share really dovetails nicely with what you just shared. So I'm speaking today from the perspective of research we've done here at the Frameworks Institute. I haven't led all this research personally. I'm really speaking on behalf of the organization. We're a group of social scientists that systematically investigate why certain social issues are hard to talk about or where those conversations get stuck, and then design and test alternative frames for moving those conversations in the direction of good policy and good evidence. So over time, we have sampled about 400,000 Americans, and they're thinking on different social issues. And depending on how you think about what counts as a health topic, probably 100 to 200,000 of those folks are, of those interviews and survey results are on health topics like community health, early childhood and adverse childhood experiences, adolescent health, health issues that come up in later life and aging, and then specific health topics like gun violence prevention, tobacco-related health disparities, patient safety, and then also quite a bit of investigation into policy domains that are those social determinants of health. So whether that's geography, we've looked at rural disinvestment and urban poverty, how Americans tend to think about housing, education, immigration, race, and racism. So I think that we've through this research, we've uncovered some pretty stable and widely shared mental models that really shape the American thinking about health and healthcare. We haven't done a project on cost per se, but we have investigated cost as a message, and I might speak to that a little bit later. What we find is what the public perceives and the way they mentally model health. First of all, is that health is the absence of illness. There isn't a kind of a robust positive sense of what it means to be healthy per se, but definitely a sense of that health is not sick. So when we asked on mental health in particular, people really have trouble defining mental health, although they can define mental illness, with some accuracy. We also see the probably the most dominant model is that health is this model of health individualism. So first is that health is a personal concern, and it is caused by personal lifestyle choices. So primarily, instead of the social determinants of health, Americans can give you 2, maybe 3 determinants of health: diet, exercise, and people will also mention substance abuse, tobacco smoking and drinking in particular. There's a recessive model, meaning it's there if you push for it, but it's not top of mind necessarily, but lots of people share that stress plays an outsized role in health outcomes. And we find that to be pretty productive idea because it allows you to get into community conditions. But mostly people see health as an individual concern, one that if there are health problems or good health, that's caused by your own decisions, but also that the problems, the effects, the consequences are primarily personal and in your sphere. So if you get sick, that's sad for you, it's trouble for you, it's a problem for your family, but just as Eric was saying, there's not a sense of aggregate cost. There's also not a model of aggregate how health shapes broader outcomes in society and how our health is intertwined. When it comes to healthcare, people do mentally model healthcare as a consumer good. And so with that comes with a set of assumptions, right? That you get what you pay for, that varying levels of quality and cost are normal, expected, and even desirable features of a system. So I think, Eric, this matches to what you were just saying about people are okay with the idea that some healthcare is better if other people can pay, if those people can pay for it. It also, it means that some people can't access it, right? Consumer goods are seen as, some people can afford them, some people can't, and that's baked into that system. So to the extent that people model, health as a personal choice, and then also as a function of the healthcare that you can get, and model that healthcare as a consumer good, the conversations about limiting costs are going to be really, I think, fraught, is what our research suggests.
Great. So thank you so much for the opportunity to be a part of this panel. I'm just absolutely delighted and so pleased to learn about this work, Julie, that you were just talking about. I can't wait to read that because that's going to really help me in some work I'm doing. My starting point for this conversation is thinking about the politics. That's what I'm really interested in. And in sort of my political science training, I learned to not really love the word political will, the term political will, that we just need political will and then good things will happen. Because I think we need to be really specific about who needs to do what, like where in the process, things, what the legal mechanisms are to make change possible. And so one of my interests is really trying to understand where policymakers are coming from and meet them there. And so a lot of my research is about speaking to legislators and other types of policymakers to understand how they view the world. And in over the years, I've been connected with the Milbank Memorial Fund and so impressed by a number of the initiatives they have, including the Reforming States Group, where they bring together state legislators and other state leaders behind closed doors, no media, just having conversations about what's happening in their states and learning across a lot of lines. And these are fantastic conversations, and I've had the opportunity to present to those groups and learn so much from them. And in the course of talking with the people at Milbank, over the years, they introduced me to a mathematician named Christina Poggle, who was in the United States a few years ago doing a fellowship with the Commonwealth Fund. And we got connected. We decided to do some research where we would use her survey skills to survey state legislators and ask them, what do you understand? What are your top priorities on health policy? And then I would go to the states and interview them and do focus groups with them. And so a lot of the work I'm going to talk about in this panel is really coming from that. And there's sort of a good news, bad news, good news takeaway from the work we've done, where the good news, the first survey that we did was in 2017, and it was with state legislators. We sent out questionnaires to every state legislator who served on a health committee or a budget committee, which ended up being about 3,000, so a little less than half the state legislators. And with the major caveat that we got a response rate of around 10%, which is typical of these types of surveys, but low, and so you can only make so much of it. And sort of the frustrating thing at first was that, maybe not surprisingly, the respondents from the left said that access and population health was their top priority, and respondents from the right of the political spectrum said that their number one health policy priority was reducing the role of government. And those are just kind of like so opposed, but everyone said healthcare costs was their number two priority. So we looked at that as good news and an opportunity to try to open up a conversation. So then I went to Topeka, Kansas, and I had a focus group where I sat down with 8 legislators, bicameral, bipartisan, so House, Senate, Republican, Democrat, and we just talked about what is healthcare costs? What does that mean to you? And then I did something similar through interviews in Denver. And sort of the expectation I had going into those conversations is that we could almost develop a sense of like a shared language, a shared understanding of what costs are and why costs are a problem. But unfortunately, the consensus broke down almost immediately. Like everyone agreed cost is a problem, but people meant very different things when they talked about cost. So they were thinking, oh, the cost to the government, the cost to hospitals, the cost to doctors, the cost to insurers, the cost to my family and my premiums, my deductibles, and other out-of-pocket costs. And so then the next question in our phase of research was to try to get a deeper understanding of what people mean about cost and how to bridge these gaps. And sort of the good news, in this latest round, we did another round of interviews and surveys in 2019, 2020, early 2020, is the responses of how state legislators think about healthcare costs is not super ideological. Like it was actually really kind of frustrating methodologically trying to interpret the responses because they were all over the place, not clear patterns. But as we did interviews, it became clear that that was actually good news, that they're not really fixed hard lines about ideology and political spectrum of how they think about costs. Everyone said pharmaceutical costs is like the number one thing they care about. But beyond that, there were actually 3 parties that people sorted themselves into: predominantly Democratic Party, predominantly Republican Party, and then a large group of people that were almost evenly split in the middle of Democrats and Republicans, who said reducing the role of government was like their lowest priority. And there's a lot more consensus about what we should care about when we think about cost than we might have thought. And I look forward to talking more about that over the course of the panel.
This is excellent. So we've kind of set the groundwork for where the public and policymakers are. And I think there's some important sort of barriers to consider. So one is this really individualistic way that people generally think about health and healthcare, and healthcare costs in particular, as it's the, it's what affects their pocketbook. It's what affects the bottom line. It's not the broader systemic costs that this workshop is meant to address. So that can be a challenge, right? How do we think about shifting and helping the public understand that their costs are affected and related to their neighbors' costs, their broader community costs, and the total cost of care. So that seems to be one key challenge. The second key challenge that we heard all panelists talk about is there's this consensus that healthcare costs is a problem, and it is bipartisan, but it's sort of a fragile consensus, right? So once you kind of dig deeper into it, it actually means many different things to many people. So if we think about that, there is an important role in having everyone come to a shared understanding, because a shared understanding of the problem can help us identify solutions. That seems to be another really important challenge that's worthy of more discussion. So for the next sort of set of conversations, I want to understand from your work what it would take to shift those public understandings, or policymakers in the case of what David described. So what kind of information, what kind of framing, what different or alternative ways of discussing these issues might create the opportunities for a mental map, as Julie described, that's less individualistic and more oriented on the common good or even the system. I know it's hard to get people to think systematically. It's really not how individual psychology works, as you each described. But what might it take? I wonder, in sort of any order, who wants to jump in to ask this question, answer this question?
I'm a framer, so I'll jump on that one first.
Thanks,
I think
Julie.
the most important thing that the people on this call can take away is to distinguish between the social analysis of a problem and the communications analysis you need to drive that issue forward. So our social analysis here, the topic we're talking about is costs. But that might not be the language, the frame that we need to break through or unlock public thinking on this. In fact, our research, whenever we have tested broader economic impacts of a health issue on public thinking, it has backfired in different ways on different issues. So when we looked at it on gun violence prevention, it was seen as just inappropriate to be talking about deaths and costs, and how if we prevented those deaths, we would have lower costs. It was just seen as a bad fit on that one. We talked about the overall economic costs of certain health issues, so the toll that tobacco takes on communities, or the broader economic loss and productivity associated with poor oral health. Both of those people ended up stigmatizing and blaming the people who were experiencing the problem for those increased costs. So that language of cost might not be the language that gets us to get people to want to manage costs, particularly with the public. I don't have data on the policymakers, and I'd love to see hear what David says about this. And so any of this consumerist language, cost, price, those sorts of things really keeps us locked in that consumerist frame. And so if we can find language that moves us more into the civic frame, right, the public square, language about responsible management, and really making sure that we aren't leaving messes for future generations or taking the long view. So there are different ways to get out of that consumerist frame, and I think that is one of the most important things we could try.
I might jump in. Yeah, I might jump in with an example from Commonwealth Fund work, which really is about creating the tension for change, or unfreezing the current discourse. And 20 years ago, if you asked most Americans whether the U.S. had the best healthcare system in the world, you would probably get a majority of them to say, yeah, the U.S. has the best healthcare system in the world. And the Commonwealth Fund over the last 20 years has conducted surveys across 11 high-income countries, thinking of them as peer countries, on the performance of those countries, and reflected in an annual publication of surveys comparing the 11 country performance. There's a Mirror 2017 is in your packet as a product that we've been putting out over the years to try to show people that, in fact, the U.S. may not be the best U.S. healthcare system in the world. And that's not that hasn't been a quick fix, but I'm sort of been impressed in recent couple of years that the discourse has changed. And actually in polling, you see that Americans actually now believe, a majority believe, we have something to learn from other countries about their healthcare systems. And I think that reflects the shift. It's also interesting, reflecting on David's comments, that state legislatures have been interested in lessons from abroad, which I think goes to the point that they're looking to solve problems in their local jurisdictions, and they're interested in solutions. If you can say it didn't come from another country, but actually is something we've done in the U.S., that actually might even increase the utility of or the acceptability of that solution. But I think I raised this example just to say, well, some people get sort of pessimistic that change is really possible, or that American values or American beliefs can change. And I think this example shows that they can change. It may take time, but with clear, visual, simple messaging and a connection to some of the potential solutions, Americans are potentially open to changes.
Yeah, I think this is great, and from my work, I'm really, when Christina and I did these interviews and these focus groups, I got really interested in this group that was in the middle, the sort of the bipartisan Democrats and Republicans, and trying to understand in what way are they more like Republicans, more like Democrats, and how do we talk to that group, and how do we frame things to appeal to that group? And one of the things that was interesting from those surveys and interviews is the Republicans and Democrats in that middle group are like the Democrats in that they say that reducing the role of government is not what they're focused on. It's not their priority. And so I think that's really encouraging in terms of like being able to have a productive conversation about the role of government. But they're more like Republicans in that disparities are not their priority either, and focusing on equity, which I really struggle with, because that's how I try to think about my work, and I think that's such an important part of what needs to happen. And so I am not quite sure where to leave that, whether that's a lesson that maybe we should downplay disparities and inequities as a path to solving it, or maybe we need to change minds about equity and make that a priority. But then the other thing that's come out of that is the Republicans in particular, I had asked them, like, okay, why isn't reducing the role of government a big issue for you? And their answer, those who are in this middle group will say, well, government's already involved in healthcare. It's a matter of getting value for what we're doing. I don't necessarily want to expand big government programs. I want to push government to think more creatively about solutions than just throwing money at the problem. But government is already doing so much, and I want to get good value. I want good management, responsible management in the language that we've heard already. So, I think some things that are challenging from that, but also encouraging.
Yeah, David, I appreciate and hear your comments, especially on the equity piece. That's an area that we are really trying to take apart in terms of how we get messages that resonate, particularly with conservatives, in efforts to move the needle on equity, not necessarily to diminish or counter or, downplay it because it's, uncomfortable, but what are the messages that are actually impactful to promote it and actually get legislation passed such that it resonates. So I'm interested in, continuing that conversation and identifying specific, tested messages and what is starting to resonate such that actually does move the needle. So definitely looking forward to more of that conversation.
Yeah, so it's, obviously there's some contextual issues in the present day that certainly heighten, per Venice's point, the importance of health inequities, racial health inequities in COVID, for instance, the broader sort of systemic understandings. We heard yesterday several speakers said, well, COVID is really helping us see, or at least some subset of us see, how we are all connected, right? So I'm wondering if you can speak more, depending on sort of where your data collection is and when it's been, on how, whether or how you're seeing any shifts in public understanding because of the current environment, because of COVID-19, because of renewed attention to the importance of racial inequities, racial justice. Where's the public in some of those themes? And is that an opportunity to think about catalyzing this shift that Eric described could take a very long time? Well, unfortunately, we want to move on these issues, right? The issues are important now. And so what role does the current context play in potentially accelerating or facilitating a shift toward the public being able to gather and a more systemic way of understanding the healthcare system cost issues?
I'll jump in on that one because we've actually done some polling and examined other polls, trends over time, which we haven't published yet, but I'll share some of the results or findings because I think they're really interesting. We've been through a sort of once in a century pandemic. I mean, it's the equivalent of World War II or the 1918 influenza pandemic. And one might say, well, if that can't change people's views, what can? And so we were very interested in repeating some surveys around the values of Americans in late 2020 that we had conducted the previous year, 2019. And a couple of interesting observations. The first is that the concern about racism and equity has actually increased in public polling. The percentage of people who think racism is a big problem in the U.S. Is 60% versus 49% 5 years ago. And in June 2020, not our survey, but another survey found that 19% of the public cited racism and race relations as the most important problem facing the country. And that actually, the last time that was that high was 1968. So that's sort of interesting to observe as well. So there is a concern about equity. There's also a greater awareness of discrimination in the healthcare system with a larger percentage, almost half, 42%, I should say, of people reporting that Black people are treated less fairly than white people when seeking medical treatment. And that's up from a year ago when it was 33%. So there's a real opportunity, I think, around equity that the pandemic is creating. The second is a little bit more of a headwind story, which is the confidence in the US healthcare system has actually gone up in the course of the pandemic. It's easy to imagine why healthcare workers have gone to heroic lengths to respond to the pandemic. People recognize the risks that they're enduring. And so we see somewhat higher, modestly higher percentages of Americans saying they have confidence in the healthcare system. In that context, it's unlikely that people would be excited about reducing spending on healthcare services when they think that healthcare workers may be at risk. So we're still sorting through the implications there, but that's a headwind that the pandemic is creating to the agenda we're talking about today.
Yeah, to that point, in a commentary that my colleague Jeff Niederdeppy and I published in the December AJPH issue that sort of discussed all of these many issues related to opportunity costs and distribution of spending, we raised that issue, Eric, which is that past social movements have often relied on what's called villainization, right? So someone has to be a villain in order for potentially the public to shift toward a greater support for policy strategies that address that quote unquote villain. So you can see that story really clearly in tobacco related policies, right? So the broad public recognition and strategic framing on the part of public health advocates as the tobacco industry as the villain may have been part of what allowed the public to come to support more aggressive indoor smoking legislation of all varieties at the state, federal, and local level. And so I wondered if you all could talk about that. I mean, when this question of healthcare system excess spending involves the healthcare system, which generally people either perceive favorably. We already heard that the status quo is an important barrier where people are generally satisfied. And then further, we have this heightened and really justified element where the healthcare system are the heroes, the nurses, the healthcare workers, the vaccine producers. How do we think about shifting public views toward a system that has so much obviously positive positive contributions to society and to local communities, as we heard yesterday, as an employer, as a source of economic engine? Can anyone jump in and comment on that puzzle?
That's a juicy question. I love it. I think our research points us to making injustice and inequity the villain in this story. If we make cost or high cost the villain, I think we've already identified a lot of problems amongst us with that as a frame. If we make the healthcare system a villain, it's really hard to then say we need to invest in really reforming that system. It's much easier for people to think about blow it up or just leave it to people to navigate on their own and get the best they can. But we have seen, similar to what Eric just mentioned, a real sense that people are shifting the way they think about racial inequality, but other forms of inequity and inequality as well. And so, to the extent that we can frame the issue in that way, I think it's not only going to lead us to better solutions if we're designing at the margins, right? Making sure the system works for the people it's least likely to work for now. We'll get those solutions that work for everyone. But also as a framing strategy, we have seen it to be, the things I cited before, where cost wasn't the winning argument, justice was the winning argument for the American public. So I think we haven't seen as much of a shift in our COVID related kind of this moment research on how people are thinking about health. People were still thinking about it in very individualistic ways. It's up to you to wear your mask and up to you to stay home. And yes, of course, diet and exercise is tougher with the gyms shut down and that sort of thing, but it's up to you to maintain your routine. Like that was still very baked into public thinking, even in this moment where it seems like we should be thinking about context, right, a lot more. But on the matter of racial and broader social inequities, we really did see some real openings there.
That's fascinating. I wonder, Venice. Oh, yeah, I was going to turn to Venice to see what her research suggests about this really exciting idea about injustice as the bad guy in the story.
Yeah, I love that framing, and fits nicely well against some of the public opinion polling that we did. Tracks a lot with what Eric was talking about. There's a super high, increased awareness of the inequities. I'll say 68% of our sample identified that there were inequities in the system. And the breakdown of that was particularly interesting, where 57% of and even though we oversampled for, low income uninsured, 57% were the majority that identified that. And when it came down to racial responses, Black voters were 30 points more likely than the overall sample to say that inequities were happening in their communities, and Hispanics 22% more likely to say it was happening in Hispanic communities. And then those that had experienced discrimination within the healthcare system was about a quarter, 25%. So that is the conversation. But I think we have to remember that racism and discrimination in healthcare is not at all new. It's kind of baked. So we're talking about healthcare systems. We also have to talk about the systemic racism system that has been operating in tandem since the beginning. Right now, we just have an opportunity to talk about it and elevate it more. And so, to Julie's point, making that the villain, is that where the traction is really? Like, what do we do systematically to change the conversation, right? If this is what voters are saying, you know, is there a story there? Is there an element that we can pull out, because it's definitely highlighted. And the point that you raised, like, we really are in a conundrum, right, with COVID and healthcare providers, you know, being the heroes here, but there's still that very same system is keeping quite a few people marginalized and segmented out. Because if they were all working together and working synonymously and tracking in the right direction, we would not see and experience the outcomes that we are experiencing in underserved communities of color and low-income populations. So there's a lot to continue to unpack there.
Yeah, I think that's a super important point, that we, you know, remind ourselves that although there has been heightened awareness of racism unveiled in the last year, racism in the healthcare system and society as a whole, of course, is a long-term challenge. I think that's also a good segue to turn to David for your perspective, both from your policymaker focus groups, state legislators. Can you talk more about how and in what context these issues of injustice and racial injustice in particular came up? And then I'd love for you to talk a little bit more about some of your work grounded in Mississippi, where you're observing the deep implications of racism and that persistent racism we just heard Venice recognize.
Yeah, thank you so much for the question. I think one of the hard things about this conversation we're having is it's all true at the same time in some ways, right? Like, I feel like the awareness of racism and racial and ethnic inequities, I think, is increasing. You know, we've heard some compelling evidence about that. But in this moment, public health has been politicized in a way that I think makes the work of addressing those inequities that much harder, when something like wearing a mask becomes a statement, a symbol of, I'm not going to let the government tell me what to do and I'm in control of myself. I think it makes it really hard to advance the ball. And so that's my one concern with this idea of injustice as the bad guy. It's sort of so nebulous that then people automatically will go, okay, like, who is behind this? And then it becomes about blaming a conservative governor or a legislator, or like, it doesn't necessarily, in my mind, though I'll have to think more about it, but it's a tough jump to then, okay, let's restructure the economy so that it's more equitable, or let's restructure systems. And, you know, to Sarah's point, the other major project I've been working on over the last few years is writing a book about these racial and health inequities in the Mississippi Delta, taking as a case study what's arguably the least healthy place in the country, and spending a lot of time doing interviews and talking with people who live there, with policymakers, trying to understand how all these systems work together. And I've learned so much. I mean, I've learned so much, and I would love to talk more about it. But one of the things I learned is that, like, healthcare costs, and this won't be a surprise to this group, but healthcare cost is just one problem in just a massive scope of problems, right? Like, expanding Medicaid, I think, would be really consequential for people living in poverty in Mississippi, but it wouldn't necessarily mean that they have a provider within an hour of them. It wouldn't mean they have a job that gives them insurance, and sort of all the layers that go beyond that. But then when you have the conversation about what's the role of injustice, what's the role of race, it often really kind of shuts down conversations, because people get defensive, especially the policymaker level, get really defensive. But I have found that Ibram Kendi's work is really powerful as a slightly different framing for thinking about this. Not necessarily you as a policymaker, you are racist, you are making, you know, you are intentionally being racist, although I think we could probably think of examples where it's happening, but try to frame the conversation in terms of, okay, what are the racial implications of the policies that have been made? And that, you know, that's Kendi's argument about how to have an anti-racist conversation, and really make the focus not on, like, the policymaker is racist, or the, you know, the healthcare system is racist, but that particular actions, particular words, particular policies are racist. To me, that's a powerful way of reframing the conversation.
David, what you just pointed out is really how important it is to think about how we talk about justice and fairness. So a lot of the ways when we test the language, it's a little different than you might hear at a rally in the street, right? So on ageism, for instance, they are the language that proved effective was a just society ensures that we all can continue to participate and contribute as we age. And so that's the concept of social justice, right? That the society has a responsibility to include and invite, but not, it doesn't sound, super lefty or anything. I think helping people, particularly people who might not instantly identify or recognize the theme of racial injustice, connecting different forms of injustice and really broadening that, it can be helpful, right? Not to avoid talking about race, but rather to acknowledge that that many types of identities, that there's injustice happening in lots of places and spaces. We have found that to be very effective as well. So I think that, yeah, if we're locating the system, right? The system is not working for everyone, and it's on us to make sure it does. That is the form of justice that we have found to be most helpful in mobilizing people who are already right there with you, but also bringing in people who are more unlikely allies on that topic.
Just add that we're trying to do a very difficult thing in linking two concepts here. One is the reduction of medical spending and wasteful medical spending, and the other is investments that would remedy some of the inequities that we're talking about. And it's very hard for people, this is where the behavioral economics piece comes in, because we know that people will overvalue losses compared to gains. So if we talk about reducing medical spending, we're actually emphasizing a potential loss, a risk that people are going to magnify in their own minds. Just we're hardwired to do that. And the second is the notion that gains in the future are less valued than gains today. And that time element of we're going to extract money from the healthcare delivery system to deliver a health dividend that has some value in the future. We're again swimming upstream against a hardwired principle. And what's most striking about this to me is that we really do live in two healthcare systems in the United States. There's one system for those who have means, who are employed, who have insurance. And there's the other system that people experience, which is for those who don't have means, who are just scraping to get by, who have serious illness and therefore are in the system a lot, but also racking up tremendous bills. And then there are the racism, the issues of racism even within the healthcare delivery system that leading to the mistrust. So in a strange way, what we're saying when we say we want to reduce medical spending is that if we don't do it right, people on both sides in both systems can experience a loss or will feel that they're at risk of a loss. Those who have means are saying, well, you're going to cut medical spending. That means I'm going to get less care. I'm going to lose. Even the people who don't have means, who are struggling in the system, see hospitals closing. They see clinics closing as a result of consolidation in the healthcare system. So they even are worried about losing what they have, which even if it's inadequate. And the promise of a future social spending dividend is difficult for most people to conceive. It's also interesting to me, though, that we've just passed and was signed into law last week one of the biggest social spending increases for children and to reduce childhood poverty that we've done in decades, probably. And focusing on that immediate gain is sort of an interesting exercise, because we didn't worry about reducing medical spending to get that. We just sort of offered it as a relief in the context of the pandemic.
If I could jump in too on this, I think one of the interesting tensions in this conversation we're having is whether to focus on cost as a problem to individuals or cost as a systemic issue. And it parallels very interestingly with the responses I heard from policymakers, where some people really, like, everything they focused on, as I said earlier, was about deductibles and costs to the quote unquote consumer. But then when I would ask some of the legislators in the middle group or on the left, which they prioritize, the individual or the systemic costs, their response was to be kind of confused and say, like, I don't understand the difference. Like, the way we solve the individual problems is to address the systemic problems. And one of the things that I think came out of that research is that maybe we don't need to actually convince everybody of that point. That it's enough that there are a core group of policymakers in the state or wherever the context is who become so-called pockets of expertise. They can make that connection, and then it's a matter of strategically framing it so that they can advance policy goals to win the coalitions or win support. But not necessarily you have to convince everyone of the connection between the individual and the systemic.
Yeah, that's a great point. So I think we heard a few important challenges just now. So one is that the salience of that loss frame. So if you talk about we want to eliminate waste, we want to eliminate low value care from an individual's perspective, that's their that's their screening test, that's their diagnostic evaluation, that's their prescription for an antibiotic, that's an individual and tangible service. And it's very abstract to consider sort of the population health, the aggregate amount of waste. That's just really hard for most people to comprehend. So that loss frame, that is a hugely important challenge. And second, David pointed out that when we talk about framing, or we're talking about wanting to come to some shared understanding, it doesn't have to be everyone, right? That there can be pockets of influence. I want to turn now to just getting your sort of reactions to the who, the sort of, we know that when you frame this entirely about a government, the government is going to make policy changes. It's going to affect costs. That's going to probably create some of that backlash we heard already, sort of priming anti-government sentiment, and also these sort of negative implications of the cost of really using that cost argument going forward that we heard Julie talk about, because it sort of activates this idea of a consumer good, which people don't want to lose. But the other alternative is to talk about these community collaborations, where you have community organizations like the United Way, in the Cleveland example, participating in collaboration with the healthcare system. And those kind of partnerships, those collaborations that CMMI and other organizations are funding, I think really shifts the messengers, right? So who has the authority in a community to demonstrate leadership, to shift the narrative, to be interviewed in media reports about what some of these opportunities are. And it could also, those demonstration projects could also help with the problem Eric identified, as these gains might be very far in the future. Well, if you're talking about a community organization right now that's able to fund new social safety net services, that is also a potential opportunity. So does any of your work engage with these questions about who are the credible messengers within a community, and kind of thinking about the government, but also community organizations, community leaders as partners in this important policy shifting work?
Yeah, I can absolutely jump in on that piece. So that is kind of at the core of what I'm working to do and expand and partner with, others that are doing this exact work, right? And believing in this notion that if the problem is in the community, the solution is in the community. Like, who are the better experts that know the day in and day out and the everyday lived experiences than the people that are actually there on the ground working to solve them, right? And so they absolutely need to be more at the table in solving this. And then recognizing that there's not a one size fits all approach. There's not a model that you can roll out and hand out and everybody's going to buy into and say, oh, hey, this works. But when you provide adequate resources and actually meet people where they are to solve the problems that they're dealing with, does that create models on the ground that could be scaled, right? We have this notion that we come in, top down and go into communities and tell everybody what they need to do, which is absolutely not the best approach. And community members often resent that. I've seen it quite often. But working in tandem and in partnership to gain those ideas and test those messages and create the trust, right? And take these, and that's kind of what we're trying to hone in our approach to the people-centered policy design, right? We have these ideas, we have these messages that we want to take back to you. Weigh in on this. Let me know what you think. How does this message resound? Like, what's the context behind how this fits into your world? Is this a solvable problem? What tweaks would you make to it? Who are we leaving out from this conversation? And then again, reinvesting into these communities. I'm thinking about standing up more patient-centered medical homes and what kind of cost implications those could have by creating jobs, synthesizing and bringing in, a total approach to healthcare systems so that it's not taxing our hospitals. So things like that are a lot of what we're starting to unpack and really hone in the power of starting with communities and starting with community-based organizations as the experts. And working in partnership with theirs is a really powerful source that I think is underutilized.
I love that point. And it brings to mind a series of interviews I did in Cleveland, Mississippi when I was down there doing interviews for my book, and thinking in particular about this one medical practice, this doctor who, as he was practicing, could just see the inequities and the injustices and the inefficiencies just all over the place, and really just developed a vision for how it could be better, and really used his position to challenge hospital policies, challenge local culture, and question, the insurance companies were, it was in terms of what they had required prior authorization versus not. It was just much more common for doctors to amputate legs for people with diabetes than actually treat things. And, and so I think that one of the takeaways in my mind is doctors in particular have a really powerful voice, local community doctors. And they are a highly respected group who can challenge the norms. People trust and respect them. And I make that point I'm almost uncomfortable making that point from a point of, from someone who sits in the world of public health, where I think sometimes doctors and the medical community has been elevated at the expense of public health and the systems level thinking. But if doctors can be partners in helping to lead that on sort of a local level, on a more global level, I think that's really powerful.
Yeah, I would just second that notion. In the 1960s, community-oriented primary care, Jack Geiger, who passed away recently, was certainly a champion of the early efforts there. And the Black Panther movement understood that health and social justice were closely linked and created a series of clinics in Oakland. I think we unfortunately haven't done enough to strengthen the notion of community-oriented primary care over the several past decades, which some of us believe would actually could produce some of the spending reductions that people would like, while you're building on a platform of accessible care. Other countries have done this. Cuba, Costa Rica, and others have really strengthened the notion of community-oriented primary care and brought together that confidence that people have in nurses, doctors, and community health workers with the notions of justice and more effective care. I think the other point about, and I really do love the notion that state and local governments and communities where these things can actually happen, because people on the ground are trying to solve problems. I remember visiting the Utah legislature and hearing about the building of housing for homeless people, that if it were a federal program, I don't think they would have accepted it, but because it was a locally generated initiative, they were quite committed to extending housing despite a conservative ideology. So I think we tend to start putting people into these columns or boxes, but in fact, I think David's made this point that there are people who are, in a pragmatic sense, trying to grapple. And the other problem with the federal level right now is that if you just look at health insurance, we did some polling. 3/4 of Democrats prefer a health insurance system run by the government, and 3/4 of Republicans prefer one based on private insurance. And actually, that runs through the partisan politics, that the sort of divide between the role of government, especially the federal government. I think that's more muted at the state and local level, not invariably, but less so than at the federal level, where I think action on healthcare reform is going to be harder to come by as we move forward.
Yeah, if I could jump on that point in particular, because that's one of the questions I had when I was in Lansing, Michigan, or Topeka, Kansas, and asking people, really kind of almost surprised by the level of conversation across party lines that I was seeing about healthcare costs, and trying to understand why that was happening. And one of the things that became clear is that once something got escalated to the media's paying attention, or this is about Obamacare or Obamacare implementation, like once it got there, then it was okay, rule of government, everyone go to their corners. But when we were able to keep it in when they were able to keep it in the realm of all these other issues we've been talking about, even as Eric's saying, in some very conservative places, I had a very conservative legislator, explain to me, like, have you heard of the social determinants of health? Like, this is amazing. Like, why don't we try to reorganize things like this? We could reduce government spending across the board everywhere. If we just had a more, a fairer, more efficient way of organizing systems. And I think there's a lot of power there, keeping the conversations local and not as like Obamacare 2.0 or so forth.
I'll build on that point. I mean, we've in the research that's in the field right now, where we are tracking kind of systematically what is changing in American thinking given the pandemic and louder and broader calls for racial justice. We have seen positive models of government on the rise. So, Eric, earlier you mentioned positive, trust in the healthcare system is on the rise. We're seeing positive models of government on the rise. Of course, there's still some partisan split there, but it was up on people who identified both as Democrats and as Republicans. So that's encouraging. It may be an opening to move some of those things. In terms of talking about the social determinants of health more often, as a way of building support for some of these cost-saving measures, I think that's really important. It's important how we talk about it, though. If you notice that that's my theme, we have found that explaining one social determinant of health, so for instance, how does housing shape health, or how does even neighborhood shape health, by saying availability of sidewalks and safe places to walk and exercise, connecting one of those social determinants of health to the determinants people already know around lifestyle choices. That's really important. It's better to explain one well than it is to list all 8 or 12 or 15, depending on your politics, how many we've got now. And that is a way that really opens people's minds up to go beyond health individualism and into the space of thinking about context. So I would just encourage everyone to think about not just, just to think about how to message that effectively.
So great.
I might just add that we are seeing local community reinvestment strategies from hospitals in housing, for example. In Massachusetts, we have an example of the local hospitals. Chicago has another example of local hospitals partnering with community. There were several examples yesterday at the session that I thought were wonderful. And that positive framing and notion of community reinvestment in communities that have been historically disadvantaged, economically disadvantaged, is another place that I think can build consensus at a local level.
I want to turn now to getting at some of the audience questions. So just as a reminder, beneath your window where you're seeing us, there's an opportunity, a tab for Q&A. So please continue to write in questions. And now we're going to turn to addressing some of them. So one question that we received early on when you were each presenting your kind of overview about evidence on what the public thinks was, how do those themes differ by particular groups? And the questioner is wondering about the Medicare population as opposed to sort of the rest of the population. Do people in the Medicare program, or people 65 and older, do they think differently about some of these issues around particularly costs? I don't know if Eric, if that's something you might be able to address.
Yeah, I can talk in general terms about, and with Medicare, it's always hard to distinguish what's the age cohort effect from whether people have Medicare insurance or not. But interestingly, the attitudes of Medicare beneficiaries split along the same ideological lines and partisan lines that they do for every other group. People with Medicare are generally satisfied with their insurance. As we learned during Obamacare, most people don't understand that Medicare is not a private insurance program. In the surveys, you can ask people how satisfied they are with private insurance. It polls around 70, 80%. For Medicare, it's 80%. So there's just a high level of satisfaction with Medicare insurance, even though it doesn't really provide all of the benefits that people might like or want. Satisfaction with Medicaid is interestingly also high, as high as it is for Medicare. So there's for those who, even for those who like the private sector, Medicare has a Medicare Advantage program, which looks for all the world like a private sector insurance. And you can sort of bypass all of the debates about government versus private sector in the Medicare population. One thing I would add is that Medicare beneficiaries are also particularly concerned about reforms, health reforms. That's actually a real lightning rod still. And so the loss framing really does come into play whenever people talk about reducing spending, especially if it involves Medicare. Medicare beneficiaries are much more comfortable talking about reducing private sector prices for for healthcare for commercial insurers than they would be for Medicare.
Yeah, there are similar trends in some of our polling data, and we often talk around this concept of the devil because they spend so much time trying to craft the insurance plans and the proper fit for them, and so it's not so much the Medicare piece of things, it's the prescription drug pricing. Where it starts to get real dicey when they have to make those hard decisions between, what kind of medical care they're going to receive, or whether they eat or provide for their family. And so I think there's those, when you start to get into those other layers that get into, other factors of cost with older populations. We actually just completed this huge project in virtual care, given the pandemic and how that we were looking to, kind of identify any gaps where that might exacerbate, issues and kind of creating more gaps where people don't have, the means to access technology or, navigate that kind of system. So I think it kind of, there's some layers to it, but for the most part, the cost piece of things kind of comes into the everyday lived day-to-day cost of healthcare, kind of pay attention to older adults.
Another question, another person in the audience asked specifically sort of to the crux of what this workshop is all about. Do you know of particular ways of discussing communicating about low value services versus high value services that are particularly resonant for the public?
Yeah, I think and I was sort of part of a conversation probably 10 years ago or so on what to call inappropriate care, waste. What was the language that would resonate best with clinicians. We were really focused. I was working with the American College of Physicians at that point. And we actually landed on the term low value care and published a paper on that because we thought that reframing was really important for clinicians. And then we had a hypothesis that because people trust their doctors and nurses, if clinicians were sort of using that terminology, then patients might also embrace it. And then the Choosing Wisely program is sort of predicated on the idea that there are low value services, that your doctor can even identify them and prevent you from getting them. And I think that framing, I think it's been helpful, certainly in the clinical community. Whether the public has really adopted that frame is less clear to me.
Yeah, I like the way the question was even framed, which is about low value, high value, and in some ways that answers the question. But when I was interviewing state legislators and policymakers, I paid careful attention to the words they were using to describe what they were doing. And there were some striking examples. The one that jumps out the most in my mind is Colorado. The governor, when he took office a couple of years ago, wanted to focus on healthcare costs, created a special office within his administration to bring together legislators and the different arms of the executive branch, and called it the Office of Saving People Money on Healthcare. Like just a really like crisp, clear, no nonsense kind of name. And so much of the work that the office has done has been framed around transparency as a goal that is arguably a shared value. Which, as I sort of started those conversations, I was thinking about research about where other ways transparency has been used in the conversation about healthcare costs, that if you just make costs transparent, magically costs will go down, consumers will, be good consumers and shop. And there's just so many ways in which that's not true in healthcare. But my sense was the people who were using this term transparency knew that, and this wasn't about let's give shoppers tools so that they can use competitive capitalism market principles and that will just on its own bring down healthcare costs, but that they can use this idea of transparency and value as a way to get buy-in, that government should have a role here in helping to advance the conversation, that if we have more transparency about the price variation and how the profit margins at different hospitals and so forth, then we can have a slightly different conversation about the role of markets in healthcare. So transparency was one word that came up a lot.
This is really interesting. My concern about some of the language that we just discussed, so low value, high value, saving people money, all of this is still within a consumer frame. So again, that point about the social analysis as compared to the communications analysis. So I don't have a tested term to recommend that we've tried on healthcare costs specifically, but I do have a parallel from thinking about childcare costs. And there what we found was helpful was to tell people that there are certain effectiveness factors that we can point to from science that really make a strong, good program. Without those effectiveness factors, kids might spend a lot of time in a program and not see a lot of benefit. And so it was really about the benefit to and framing that you do want the work to be effective. It wasn't about cost, but what you got were high value services, right? And so really thinking again about all the ways in which the language of dollar signs, right, leads the conversation in a certain direction, which frankly is away from this broader public health frame that we want and the shared frame that we want.
I think that's a really important point because the thing we often discount is that there's a very aggressive and assertive marketing strategy for high cost services that may be low value services. But we're countering sort of marketing mentality and set of messages around this particular MRI machine is going to be better than the other, or digital mammography is better than the standard mammography. I mean, there is example after example of actually, there's a wonderful article called "The $1,000 Pap Smear," which was about the changeover to a new technology for Pap smear detection that is a little bit better, but the cost is much higher, and the system has to bear that cost. But as soon as it got established that this was somewhat superior diagnostically based on sensitivity and specificity and things that people don't even really understand if they're not in the clinical care setting, this thing caught on, and it's now everywhere. And the same with digital mammography. Those machines sort of took over, and they're much higher cost. So if we appeal to low value, we're not really even addressing that issue of high value services that are even more expensive than the high value services we already had. So that's another paradox we're confronting.
Yeah, I think you raise a really important point, Eric, about we need to consider messaging around this issue in the context of the broader messaging ecosystem. So in my work, I'm often thinking about the competitive sort of quote marketplace around information and messaging, where we can say, you know, as sort of public health and policy people, sort of what the types of messages that we would want to see become more common in framing these issues. And yet there are, you know, industry, news media, political ad campaign messages, which actually, at least in 2018, my research group has talked a lot about costs from different perspectives. And these are political candidates in that, you know, totally prolific ecosystem of political ads offering their own explanations for causes and solutions around these issues. So industry, marketing, political campaigns, broader media coverage, and then sort of the influence of public health, which of course tends to be a smaller contributor to the discourse, unfortunately. I want to turn now to a few more questions. There's sort of a bundle of questions that speak to geography in different ways that I'm hoping you can respond to. So one set of folks online responded to Eric's comment about seeing changes now with sort of the openness to international comparisons, right? So maybe there's a role here to look at other countries for insights and ideas around the US healthcare system. And another couple people who are asking whether some of these state-by-state differences might have traction, where, and maybe this is a question for David to talk about, where, you know, a model system in a community or a local context in one state, can that be influential in another state considering how to address these issues?
Sure, I can start. And I love this question. And I think this is such an important point. And one of the things that I love about studying state policy and politics is it's so different state to state. And so when we did our latest round of interviews and surveys, we were very thoughtful in making sure I went to all four partisan combinations of governor and legislature. So Republican governor, Democratic legislature, which there's only 3 states in the country that, you know, are like that. We went to Vermont, and then all the other combinations. And so just on a political side, I think absolutely the local context matters so much in terms of whether it's possible to have a conversation in the middle. You know, I went to Columbia, South Carolina, and frankly, people said there's no conversation. It's not like there was a conversation and people reached a stalemate. You know, it was just that it shut down with the Affordable Care Act implementation. But in all the other partisan combinations, there was a lot of opportunity in the middle. And so as I tried to explore, like, who are the Democrats, who are the Republicans in the middle, it seemed that the real split that I saw was rural versus urban, and then suburban too. Like, how people, like, where people came from really shaped how they viewed that conversation. And so in Colorado, for example, the really rural Republicans, you know, were saying, like, okay, ideology is important, party's important, but we have such deep problems where we live. Like, I'm willing to, you know, have conversations about how can the government help me. Whereas then it was in both Michigan and in Colorado, to some extent, the more suburban Republicans who were a little bit more what we might think was the Tea Party, or sort of like the role of government was front and center in their minds. And then this question about learning across state lines, I think is such a powerful one. And I'm not, and sort of, I love it and I struggle with it at the same time, in the sense that I think there is so much to be learned across state lines, and there's so many places where state leaders are having conversations, the National Association of Insurance Commissioners, Medicaid directors, and so forth, so much learning, and so many surprising combinations of friendships and partnerships. I mean, I've heard so many times, you know, someone in Idaho will say they pick up the phone and call someone in Vermont, and, you know, they compare notes. But there's also some really interesting political science research that shows that a lot of times what we think of learning across state lines is just mimicry. It's just seeing like, oh, other people are doing this. And, you know, we don't actually have evidence about whether it's better or not, or, you know, the implementation science type literature about, you know, inner and outer context, how different things are, and whether what worked here will work here. And so there's a fair amount of just sort of mimicry across state lines, which sometimes can lead to good lessons and sometimes doesn't.
Yeah, I'll just add, you know, the Commonwealth Fund stakes a lot in a state scorecard that we publish on a regular basis to do state comparisons. And I think one of the challenges is around, David's outlined several of the challenges I think are interesting. Another one is around peers. Who are the peers for this comparison? It's really easy to discount those comparisons if Mississippi says, well, we're not Massachusetts, or Utah says we're not California, and we never want to be California. So don't tell us anything about what California is doing. Interestingly, the international comparisons from state to country might be a little more compelling, just because people don't have a context for at least a political or sports-related context for a direct comparison, or any hard feelings about what that other jurisdiction is doing. And actually, the where the rubber hits the road, I think, the peer comparisons are useful to get people motivated to think about or investigate the problem. Where the rubber hits the road is on understanding the lessons that are conferred from that other jurisdiction. And really, one of the things that we have tried to do, and I'm not, you know, I think mixed success, is to bring experiments from abroad into the local context of the United States and see if they can work somewhere in the United States, because a demo in Detroit is probably a little more likely to get traction than a demonstration in the Netherlands, which has such a different system. So I think some of the hard work is around examining what lessons can be taught, and what, as David said, what are the inner and outer context issues that are going to come into play, and then really showing in a demonstration setting that these lessons from abroad can work, or that lessons from another state can translate to my state.
I think for those insider conversations, so with people working in systems change, with policymakers who are deeply engaged, the international or state-to-state comparisons can be incredibly powerful for all the reasons Eric and David just pointed out. For the outside game, for public thinking, I think it's really important for us to remember that Americans hold a deep model of American exceptionalism, that whatever we are doing is by definition better than what other people are doing. And in saying we have the worst X in the world, it really falls on deaf ears, and it is heard as a deeply partisan cue. So it is one of the things that contributes to a more polarized discussion. Thinking about so a phrase that we often encourage people to use is talking about the concept. So we want to borrow what's working elsewhere, learn from what's working elsewhere. And you can, in most contexts for the public, be less than specific about what the elsewhere is. If you're going to mention a particular location for the idea, just remember that we think of countries and states like people, and so they are messengers in a way. And so an example from Cuba is not going to be a great messenger for a broad swath of the American public, right? And although it's true that we don't have associations with a lot of countries, that does not stop the human mind from filling in what they think they know and what they heard one time. So anytime we've used international comparison data, Americans have have found a way to rationalize their way around it or through it with cultural stereotypes about that country, right? So Chinese education outcomes are higher because, you know, that culture supposedly is very, you know, respectful of authority. And so they double down and work hard. Russia has a different in criminal justice, you know, we have just as many people incarcerated or more so than Russia, which we're drawing that message is trying to draw in the sense of them as an authoritarian state. Americans said, well, that's because their cops are corrupt and ours are really good at catching the bad guys, right? So it doesn't matter what you put at people, they will find a way to rationalize it through American exceptionalism. So for your social analysis, for your deciding on your policy, absolutely look to places that are getting it right, but messaging wise, it's tricky and I think should be used with care.
I'll just mention one way we've tried to thread that needle, which is to invoke several countries that have accomplished something that the U.S. hasn't yet been able to accomplish, or the U.S. could do better. And then we point to the differences among those systems, the different personalities, and say, no matter what type of person you are or what type of system you have, there is a way to solve this, and there will be a uniquely American solution based on the lessons from these other countries. And that seems to a little bit thread the needle that Julie so well described.
That's a good one.
I was going to say, I don't have any direct experience in terms of crafting, you know, state models and comparison, but am very much a part of the conversation that you alluded to, David, on the policy implementation science and how we build the evidence for those tools that state officials can take, right? Like, what are the actual elements that they will buy into to say, hey, well, the state is doing, you know, this, or what are the methods of implementation within context that actually work. So I appreciate the question and bringing that to the forefront as we continue to think through like the policy implementation science of this and the evaluation and building the evidence of figuring out what works, but then taking it a step further to say, well, what is it that policymakers actually want? What is that tangible product that they can use in the model application approach? So appreciate that.
There's a couple specific questions around the framing around the core question of the workshop here that I just want to bring to light. So one is there value in a communications campaign that describes the unwelcome physical and economic outcomes associated with too much care? And so think on that. And then the next question looks at, you know, recognizing the recent legislation, the American Rescue Plan, that included, as Eric mentioned, a suite of upstream investments beyond what, you know, maybe some of us even on this panel might have imagined was possible or feasible, certainly 6 months ago, certainly a year ago. And so the question is allocating for reallocation from healthcare maybe just too difficult a lift versus just advocating for those upstream investments on their own, like we saw with the recent legislation? Any comments on that? So two questions. One is really focusing on the unwelcome physical and economic consequences of too much care. And so I don't know if that could be anything from the actual sort of adverse events that people might experience when they engage in sort of too much medical care and those economic downstream consequences, whether that be follow-up care and so on. And the second is, what about simply framing the importance of investing in social services and the social safety net?
I'll jump in on the second because I actually think that's the solution to this problem at this point where we are. As I said earlier, I think it's too hard a lift to get the general public to tie these two notions together, that there's a health dividend and we have to rob Peter to pay Paul. And we've now seen that it's possible to make a social investment that could have health consequences and spending consequences for years or decades to come. So I'm and again, to escape the loss framing, which we've talked about earlier, I think that notion of focusing on the investment, especially in the wake of the pandemic and all of the inequity that it's revealed, could continue to be a powerful frame for the near term.
I tend to agree with that making an affirmative case for what you do want is always going to be has some benefits to it, right? That we've mentioned. It avoids some other problems. There's a risk sometimes when people assume that that means just go all positive, right? So making an affirmative case or saying what you're aspiring to for is really important. But there does need to be some tension in the plot, right? There has to be a problem statement somewhere. Otherwise, the solution is seen as a nice extra or a luxury, or why do we, what is the problem we're trying to solve? So I think there might be a way to, within that story, talk about if we fail to take action, right? Here's what we won't get. And so it's tapping into that sense of loss aversion, but without saying, but not associating it with your healthcare that people don't want to lose, right? But rather the collective consequences are missed opportunities and that sort of thing. And I think it's important for that story not to get into zero from some framing of healthcare or education, right? Or those sorts of things. Zero-sum framing very quickly leads to us versus them thinking. And that's really politicizes an issue and polarizes an issue more so than is helpful for the goal you're trying to get to.
Yeah, I think that's right. And I think it might also require greater comfort within public health, or, from the point of view of people who are motivated by addressing health inequities to do things that aren't called health, and to advocate for things that we don't necessarily, like the way to achieve population health might be through education reform or through housing reform. We don't necessarily have to convince people that it's health too, like if we're advancing the goals of safe, equitable housing and equitable education and so forth.
I always think there's benefit in investing on the ground, because as we're all collectively saying, there's a broader benefit, right? What happens if we solve for equity? What happens if we solve for, where people are? What are the, continuous effects in all of those areas? So, and I can't help but wonder if that doesn't address the question, and I might not be 100% clear on what we are defining as unintended consequences, but if that is a method for solving for what we might define as unintended consequences of too much care, right? Because apparently there's a breakdown in the system somewhere that's driving people to, overuse, if you want to use the word, or be a high healthcare user. Well, why don't we drill into where the problem is that's driving this high healthcare usage? Probably it's somewhere related into the social determinants. So if you invest in the latter, would that solve for the unintended consequences?
Yeah, and I was going to come back to that question of featuring harms or unintended health consequences. That's been an incredibly difficult case to make. The safety movement for 20 years has tried to point out the difficulty of unsafe care and the consequences, and in part as you have to be a vigilant consumer to avoid the problems that healthcare can create. It's very hard to get traction on that because it's very hard for people to understand what excess care really means. It's also clear from international comparisons that we're not that tremendously out of line on utilization of services. We have fewer doctor visits and fewer hospital beds than several other high-income countries. It's the prices that are the problem in the U.S. And that actually seems to be more, but going back to the consumer notion, the idea of like, well, why should I be paying this for this service in the U.S. when I could get it, the same service in Canada for less? Actually, drugs, I guess, would be the apt comparison there. And so I think that narrative of fairness around pricing is far more likely to get traction. It's also really hard to, despite the research that's been done on inappropriate care. Actually, early in the 1990s, I did a study on cardiovascular procedures and inappropriate care. And it turns out that the health consequences of inappropriate cardiovascular procedures are almost minuscule. They're almost unmeasurable because most people who are undergoing unnecessary procedures were low risk to begin with. So you didn't really harm them. You inconvenienced them, and you may have cost them days in a hospital or money. but there really aren't measurable health outcome consequences of a lot of the inappropriate care that's provided. So it'd be hard for people to, I think, to relate to that.
And a further complication to that is one commentator I noticed mentioned there is a challenge when we're talking about putting the onus on the public, right, to navigate high value, low value care, overutilization of services or not, when often it's, as a commentator pointed out, the physicians who are prescribing those services and making those referrals. And so efforts, I know that you mentioned earlier was the Choosing Wisely campaign that seek to use, physician as the targets of that campaign. So I think that's another important point about the shared responsibility and thinking about, from a communications and messaging framework, this sort of multiple and many targets of communication. We are reaching, oh yeah, go ahead, Eric.
Just wanted to add one other thing, because I think Venice made a really good point here, which is about the services that we're talking about will generally, they're not visible in the same way as the other sort of needs that there are in the system. And there are other solutions. So the example of chemotherapy for people with advanced cancer, there was a lot of overuse of that service in the early 2000s. They changed the payment incentives, and overnight the use of that service dropped, the inappropriate use of chemotherapy. And so I think there are other levers to look to other than the consumer, where we're likely to see a bigger impact on unnecessary spending.
Excellent. So now we started this conversation talking about sort of how do the public and policy makers conceive of the major issues in healthcare system and healthcare policy. We shifted to talk about how the public understands these the importance of these larger social investments and what might be some compelling frames to highlight those systems, the injustice and the need for investment in social services. And Venice made an important point that if we are focusing on investing there, that could, we would hope and expect, and the evidence suggests that certain programs would lead to a healthier population, which then might shift back in thinking about reducing some of the problems of the utilization or overutilization we see in healthcare. So I think we made a really interesting arc in this great conversation today. So I want to ask each of the panelists to close with just a short comment on what you're taking out of this conversation. What key insight did you have from engaging together? Or what is some sort of final lesson you would hope to impart on the audience listening today? I'd like to go in the reverse order that we started. So David, not to put you on the spot, but you'd be up first. What is the final insight you want to take away?
Yeah, first of all, thank you, Sarah, for moderating this panel. This has been so fun to be with all of you. I've been thinking a lot about a question that's been, I think, a little bit embedded in the conversation, which is what's the relationship between public opinion and policy change? Do you need to change the public's mind in order, like before changing policy? And I'm struck by some research which is showing that, or at least making the argument that the way to change the public opinion sometimes is through policy change, that they're sort of both. And I don't think they're mutually exclusive, but I think that's just a powerful thing to keep in mind. And the other sort of overarching theme that has been present in my mind a lot is just how important these conversations are that we're having now. And so, in my teaching, I often bring in John Kingdon's theory on policy windows and what's necessary for a window of opportunity for policy change. And the simple idea is that you need consensus on what the problems are that need solving. You need consensus on what the available solutions are, and the politics need to be there, right? And so there's not a lot we can, at least that I can do as an academic in some ways, to change the politics. But when the politics do align, if these conversations about problems and policy solutions haven't been happening, then you missed that window of opportunity. And I think, unfortunately on healthcare costs, what's clear from my research and maybe this conversation is that there's still not yet a clear consensus on what exactly are the problems that need solving across the country, right? Like there's lots of different views on what these problems are. I think there's more consensus than we realize, but just these conversations are so critically important to solving these problems.
Thanks, David. Julie, what are your key insights?
I'm quite struck by how different the research each of us brought to this conversation was, and yet how much of it converged and pointed in really similar directions. So I'm taking away the fact that communications conundrums are often empirical questions. We tend to, I think, in a world dominated by marketing and entertainment, think that it's all art and no science, but there's a real science to figuring out what to explain, what to emphasize, and what to leave unsaid. And so I would just, I guess, encourage the folks who tuned into this session to dig deeper into that, to really look for the evidence and the implementation strategies, and think about narrative shift as one of the strategies that the roundtable could be learning about and using, right, to build population health.
And I'm reflecting on the fragility of political coalitions, and especially in an era where this is actually more partisan than the last 100 years. So we have to go back to the 1890s, according to John Oberlander, to find a similar era of political polarization at the federal level. But in spite of that, the interesting undercurrents of shared values, shared beliefs that, and in particular, the window that's opening around equity and social justice, and how we can leverage that in this conversation on this topic of spending and the health dividend.
Which is a perfect segue to my takeaway, thinking about, like, I feel like we've lost sight of people in the political polarization of health and healthcare in the healthcare system. But taking that opportunity back to really re-examine the role of equity and looking at the healthcare system through a different lens, right? But most importantly, shifting how we talk about health equity and achieving it, and framing it as a benefit where everybody ultimately wins, and not a loss where if you do promote equity, it's not taking away from something else. Like, this is a holistic approach that everybody can ultimately benefit from.
Thank you, Venice. That's a fantastic way to close out this conversation. So I want to thank each of the panelists for devoting the time today, 2 hours, to having this really important conversation. I also want to thank everyone in the audience for joining us for this third session of the workshop on U.S. healthcare expenditures, cost lessons, and opportunities. There will now be a 1-hour break, and so your break's starting a little bit early, but please join us again at 2 p.m. Eastern for the fourth and final session, which will cover research priorities. Thank you.